Recording.
Hi everyone. This is Sharon Byron from TrueCode, and I'd like to welcome you to today's webinar, What's New in ICD-10-CM, presented by Joy King Ewing, TrueCode Consultant. I'm joined today by Karen Scott, TrueCode's Director of Education and Training. Hopefully by now you're all familiar with TrueCode, but for those of you who may not be, we develop encoder technology that's used by hundreds of hospitals, consulting firms, and payers. We have a unique approach to coding that's been proven to increase coding accuracy and productivity, and we have a workflow that coders love. We work with most EHR vendors, so if you're interested in learning more, we would love for you to join us at an upcoming web demonstration, which you can register for on our website. Before I introduce Joy, I just want to review the process for receiving your CEU certificate. At the conclusion of this webinar, there will be instructions with a link provided. You can follow that link and you will be asked to complete a brief evaluation. Once you submit that evaluation, you'll be able to download your CEU certificate. If you have any questions or any problems, feel free to reach out to me at cbyron@truecode.com, or you can reply to any of the emails you've received regarding our webinars, and those will go to me. I also want to mention that we did send out handouts to attendees of the live presentation, but if you would like a copy of those handouts, you can also reach out to me and I will be sure to send you those for your reference. Okay, so now I would like to introduce you to today's presenter, Joy King Ewing. Joy is past president of the Alabama Health Information Management Association, distinguished member of the organization for 2003, and she's held several positions on the AAHIM board. She owns Joy King Consulting, LLC. Joy conducts coding CDI audits for inpatient hospitals, and she works as an independent contractor with Administrative Consultant Services and TrueCode. She offers presentations on coding, clinical documentation, and other topics relating to coding and healthcare reimbursement. She's spoken at multiple state and national meetings on a variety of topics. We are thrilled to have her joining us today. So Joy, with that, I am going to hand it over to you.
Thanks so much, Sharon, and welcome to this webinar. I'm going to briefly walk you through the coding changes that are going to go into effect. Well, they actually already went into effect on Friday, so hopefully you are not getting any October 1 discharges quite yet, but you should be momentarily, so this will hopefully still be timely for you. I want to start with, well, my slides were moving great before, and now I'm not getting them to move, so let me see what I can do here. Sorry, getting used to a new system here with recording. I'm not going to go through the objectives, but you can see that basically I want to make sure that you are understanding the new revisions for fiscal year 22. These first couple of slides are just a list of the new MCCs and the new CCs that were actually printed in the IPPS final rule for fiscal year 22. Those two, those in red on this slide and the next, you'll see were already approved for January 1. So they actually have already been in use for a little while. CMS included them in this final rule for IPPS because they were not listed in the final rule for last year. So they wanted to make sure that you had access to that. Now I want to kind of talk about just a couple of things in the IPPS final rule that I think are significant related to coding before I actually start into the code changes. First of all, on this slide, you can see that there are 3,490 unspecified diagnosis codes that are CCs and MCCs, where they have a category that has laterality specified in it, but they also have an unspecified code. CMS came very close to changing all of those unspecified codes to non-CCs for fiscal year 22. And fortunately for us, they decided to postpone that change a little bit longer to allow for further education of the coders on the updated guidelines and to offer assistance to providers on the education that's going to be needed. These codes, as I said, relate to laterality, which actually doesn't impact severity right now, but that's probably going to change going forward. And they've also developed a new MCE edit that's going to start flagging those claims if a code on the CMS list of unspecified due to laterality is found. In that case, it's going to be the physician's responsibility to determine if there's a more specific code supported by the medical record documentation. If after reviewing the chart, they cannot identify additional specificity to identify laterality from the record, or the physician decides based on the documentation of that record that he can't clinically determine what the laterality is because of the nature of the disease or condition, then he needs to provide that information in the remarks section on that claim. If that doesn't happen, then those claims are going to be returned to the provider. So I wanted to make sure that you were aware of that edit that's going to go into effect April 1st, rather. Also, the other thing that sort of relates to this is that we're going to start getting new code updates each year in April 1 and October 1, starting with April. For this upcoming update for April 1, the new ones that are proposed out there are all related to COVID vaccinations. And in general, those April 1 updates are not going to be the main update each year. They're just going to be, we've had some COVID things come out in April 1, et cetera. So it'll be things like that. So now I want to start into the changes in the guidelines, the general guidelines that these both kind of relate to what I've just been talking about. The first one, in the level of detail, they've added some additional wording there in bold to code to the highest number of characters and to the highest level of specificity documented in the record. They are really starting to crack down on this issue more and more as we're getting paid by value-based purchasing, and they're risk adjusting based on those codes. And then they've added this new guideline related to laterality, and they basically have said that if it's not documented by the patient's provider, we can base the code assignment on medical record documentation from other clinicians, and in a few minutes you'll see how they have defined that. So this is going to be a similar situation to the BMI, pressure ulcer stage, and some of the things that we've already been able to pick up specificity from non-provider documentation. And of course, they remind us that if there's any conflict between what the other clinicians stated and what the attending stated, that you would need to query those for clarification. They're basically coming down with the position that unspecified side codes should very rarely be used, especially in the inpatient setting. So they want to make sure that we do everything we can to start trying to clarify that. And it's going to be something that we're going to need to start looking for now and working on now as we go into this first fiscal year, so that when they come out probably with the MCC change next year, we will be already have the data and already be in the habit of, getting the documentation more specific. So this guideline basically added some verbiage about what clinician is, what is the definition of clinician. And you can see here that they're saying it's other than the patient provider, refers to healthcare professionals that are permitted based on regulatory or accreditation requirements or internal hospital policies to document in the patient's official record. And the exceptions do include this list. As I said, we've already talked about BMI, pressure ulcer stage, et cetera. So they've basically listed all of that out. And then they've actually added a little chart here. As they continue to add things to this list, they've put it sort of in chart form so that it makes it easier to see all that we can now do. And laterality and blood alcohol level are basically the two new things that have been added to this list from previous guidelines. And so you can see they've also added some verbiage here about making sure that you have an alcohol-related diagnosis from the physician to go along with that blood alcohol level, just like we have to have a diagnosis for a pressure ulcer or something related to BMI, like overweight or underweight or obesity, et cetera. And they also have talked about the codes for social determinants of health and the blood alcohol levels, and all these codes that we're talking about should be secondary diagnoses. So another general guideline that's been added is related to signs and symptoms. They've added a new third paragraph to the previous guideline about this. And basically what they've added here has been in the introductory section to the official coding guidelines for a long time, but they've actually pulled them in as a specific guideline with a specific reference number, which I think will be helpful if we have to use this guideline sometime to provide rationale for a payer denial or something like that. It'll make it an official guideline that we can quote. And then they added some additional sentencing here at this use of Z codes related to providing additional information relevant to a patient encounter. That's really the purpose of the Z code in many cases. So now getting into the chapter specific codes that we have, you can see here that we have a new code for anaplasmosis or aphagocytophyllum, which is transfusion transmitted aphagocytophyllum. And then you have a lot of changes with the excludes 1 and excludes 2 notes. We have a lot of changes throughout the new changes for October 1 this year that relate to that. In many cases, they're changing excludes 1 to excludes 2. And just be reminded of the fact that that means that we are allowed to code both of the codes together when it's an excludes 2 note. So it's important to pay attention to those as you go through. And then we also have this change related to RSV, and you probably are aware of the fact that we've had an epidemic of RSV cases this season as well. It's a very unusual amount of cases and a very unusual time of the year to have that. But they've changed the excludes note tier from a 2 to a 1, and they basically said here, if one of these codes applies, then you're going to use that code rather than the sequela code that's up higher on the slide. Then we have some wording about HIV disease, where they're basically just telling you that that's going to mean they have actual active HIV, which would be coded to B20 rather than the Z21 code for asymptomatic HIV. And then they've also got a new guideline about history of HIV being managed by medication, and telling you that you would code the B20 as principal, and you would use that Z79-899 for long-term medication use. Then we have a couple changes to the coronavirus infections related to signs and symptoms. We've got some new more specific codes for cough this year, so they've made some changes to the codes that were in that guideline. And they've also got this additional sentence that they added for follow-up visits for individuals with symptoms or conditions related to a previous COVID-19 infection. See guideline, and they referred you to another guideline. Then moving on into the Neoplasm chapter, we have new codes now for bilateral ovaries. So that means we no longer are going to have to code out 2 separate codes for right and left ovarian malignancies, which is good. And you can see that is a CC code. And then we also have a new code, category C84.7A, anaplastic large cell lymphoma, ALK negative breast. Basically, that is a disease not of the breast tissue itself, but of the capsule that surrounds the breast tissue, or the breast implant rather. And typically the patient will present with swelling of the breast. It is considered a major emerging disease by the World Health Organization, and they are finding it primarily affects women that have implants with a textured surface. I've actually seen some women interviewed who underwent a bilateral mastectomy and breast reconstruction for cancer, and then they ended up getting this cancer as well of the implant itself, which is really a bummer situation to have to go through. So they are trying to make sure they can capture this and find out how often it's happening. And you can see it has a use additional code note to identify that they did have a breast implant and or they have a personal history of breast implant removal. The next thing that's listed on here, this is a current code, but you can see that an excludes 2 note has been added with a new code that we're going to talk about in just a moment. This code here that we've had in place is for primary thrombocytosis or thrombocythemia. They're basically synonyms of each other, which means an elevated platelet count. And this primary thrombocytosis that's coded to the D47 category is considered a neoplastic condition involving blood or bone marrow. And you can see that that's a non-CC code. And then here we have a guideline related to the breast implant associated large cell lymphoma that I just spoke about a minute ago. And it's basically telling you to code it to the C84.7A and not to assign it to a complication code from Chapter 19. And then moving on into the diseases of the blood, the first new codes we have up here are related to pyruvate kinase or PK deficiency. And this is associated with red blood cells. It's a rare congenital hemolytic anemia that can lead to shortened red blood cell lifespan, and it results in chronic hemolysis and anemia. It can be mildly symptomatic anemia and range all the way up to very significant anemia that requires regular transfusions, has lots of manifestations and complications, and requires continuous monitoring by a hematologist. You can also see that we have an excludes 1 revised to 2 under this neoplastic anemia due to neoplastic chemotherapy. And then here is the new code for the secondary thrombocytosis or thrombocythemia, the D75838. And in parentheses, it tells you that it's reactive or secondary. This secondary is not considered a neoplastic condition. So they wanted this new code to be able to distinguish the non-neoplastic from the neoplastic, which we were not able to do prior to October 1. It also tells you here that you need to code also the underlying condition if you know what it is. Because typically this secondary is called secondary because it is caused by some other condition. Also, we have an additional code note that was added to this D89.44 to give you some additional things that you could add here to fully explain this situation. And then we have other nutritional deficiencies, that E63 code there, that they've revised the excludes 1 to excludes 2. So we have a whole list of conditions here that now can be coded along with the E63 if applicable on a particular patient. The Niemann-Pick disease, or ASMD, acid sphingomyelinase deficiency, has been split out into all these new codes to capture type A, type B, and type AB. This is an autosomal recessive single gene disease. Type A is the early onset neuropathic form that causes failure to thrive, hepatosplenomegaly, progressive neurological degeneration, and death, usually before the age of 3. So it's a very serious type. Type B is usually diagnosed after age 2, after hepatosplenomegaly has shown up, which that is the most common manifestation of this disease. It has a slower progression, usually has very little or no neurological involvement, and patients can actually live to adulthood with this type B. And now we have also a code for type AB, which is in between type A and type B. So it has some manifestations that type A might show, but typically not as severe as type A. They may develop neurological symptoms during childhood or other manifestations that can increase mortality. So it gives the physician a better idea of what kind of care and follow-up is going to be required for these types of patients. Now we have a guideline that's been revised for diabetes. As you know, we have been told in previous guidelines, forgotten how long ago that came out, that if they're on insulin and oral hypoglycemics of some type, that we only code the insulin use. Now they're changing that, and so in the situation where they're on 2 types, insulin and an oral hypoglycemic or non-injectable non-insulin, you need to code both of those types of codes. And I'm assuming they're doing that so that they can better capture, what is being required to keep someone's diabetes under control. Then we have the mental and behavioral chapter. One of the main things is the F32.9 code, as you, I'm sure, are aware. If you have any kind of documentation of depression, which is about all we usually get on the medical record, it codes automatically to F32.9 .9 in the title for that code is a major depressive disorder, single episode, unspecified. They deleted that code and replaced it because the expert subject matter experts were evaluating that and determined that that was clinically incorrect to code all of those things to F32.9, depression not otherwise specified, to a major depressive disorder. So they want to make sure they can distinguish between what is truly a major depressive disorder and what is just depression unspecified. So we have this new code F32.A to cover that. Then we have a new code F78.A1, SYNGAP1 related intellectual disabilities. We have a large code also note that was added here that has several different diseases with their codes listed here. Again, remember that use additional code gives sequencing direction, but code also does not. Code also means the sequencing would depend on the circumstances of the encounter. So you want to code that code, and then you want to code any related condition and then determine which of those should be sequenced as principal. Under F84, we do have a used additional code note here that was revised to a code also. So again, we're losing the sequencing direction related to that F84 going forward. A guideline, we had a guideline change, excuse me, last year about this issue, but apparently it's still unclear. So they are adding additional wording to show you that these reportable conditions are only to be a substance-related disorder. They have this part in parentheses was actually added last year, but they've made a little bit of change in the wording here. So make sure that you pay attention to that if you have to use that code for these unspecified psychosubstance use codes. And then we have guideline, additional guideline here related to that, where it's basically telling you that if you have medical conditions due to psychoactive substance use, abuse, or dependence, they are not classified as substance-induced disorders. Instead, you're going to assign the diagnosis code for the medical condition as directed by the index, and then you're going to add the appropriate psychoactive substance use, abuse, or dependence code. The example they've given here is if you have alcoholic pancreatitis due to alcohol dependence, you're going to code the code from K85.2, alcohol-induced acute pancreatitis, and then the appropriate code from F10.2, rather than coding that to F10.288, alcohol dependence with other alcohol-induced disorder. And this way you get to clarify what is the specific disorder that the alcohol use or dependence is causing. And then we also have an additional blood alcohol level guideline, again, reminding us that we must have the provider document a condition classifiable to category F10, alcohol-related disorders, documented on the chart in order to use that blood alcohol level code. I don't know whether you have a facility policy about blood alcohol level coding, but you need to put one in place. Either we're not going to code it, or if we are, this is how it's coded, so that going forward you'll be able to be in compliance with those new guidelines. Moving on into the nervous system. Again, we have a new code here for GO4.82, acute flaccid myelitis, along with an excludes one note under there. Acute flaccid myelitis is a rare but serious neurologic condition that affects the nervous system, and it's characterized by inflammation of the central gray matter of the spinal cord. It causes the muscles and the reflexes to become really weak. Sudden rapid onset of flaccid paralysis can happen in a single or multiple limbs within hours or days. The symptoms are often preceded by a febrile respiratory illness and sometimes pain in the extremities. Respiratory failure is the most severe symptom that occurs when the muscles involved with breathing become so weak that they can't really, breathe correctly, and they end up on long-term mechanical ventilation. Most of these cases have occurred in children from age 5 to 9, and it can lead to lifelong disability. So it's really can be a very serious situation. Most of the severe cases result in being completely limp or flaccid and paralyzed. Also, just moving down at the bottom of this slide, note that we do have some terms deleted from the excludes one note that was under GO5 and added to a code first note. Again, code first would also give you sequencing instructions. So pay close attention to that if you happen to be coding something that falls in that category. And then a new code here on this slide, G44.86, Cervicogenic Headache, also has a code also note for the associated cervical spinal condition. This is a type of headache that really is caused by referred pain from something that's wrong in the neck. Usually it's something wrong with the cervical spine, either the bone, the disc, or the soft tissue has a disorder of some kind, and the pain is referred to the head, as well as being accompanied by neck pain in many cases. So it is going to be important to follow this code also note and add a cervical spinal condition if it's documented. Also note here that this term excludes one was revised to Sjogren's syndrome. You're going to find out in a minute that they've revised several codes to that term. And then we have some major changes with toxic encephalopathy, G92. They deleted the code first note, first of all, and they've split it out on this slide and the next slide. And this slide shows immune effector cell-associated neurotoxicity syndrome, or ICANS. One of the new cell therapies that's been a great advancement in treatment of relapsed or refractory leukemia and large B-cell lymphoma is chimeric antigen receptor T, or CAR T cell therapy. But they have found that some complications to that treatment have been observed. And two of the most prevalent are cytokine release syndrome, and you've probably heard that term related to COVID-19, because they believe that that's what COVID-19 causes in the body as well. And the other one is immune effector cell-associated neurotoxicity syndrome, or the ICANS. It's characterized by a pathologic process involving the central nervous system after any immune therapy that activates the T cells and or the immune effector cells. Signs and symptoms can be progressive and include aphasia, altered mental status, cognitive impairment, motor weakness, seizures, and cerebral edema. They have a grading system that I have listed on this slide that's going to help the physicians categorize the different types of symptoms that occur so that they can help determine the best types of treatment methods and predict the resources that are going to be required with these different patients. Up until now, they have not been able to capture any of that specificity. And then moving on to the next slide, we have some additional changes with G92.8, code first, note. Again, that's a sequencing direction there. And use additional code is also a sequencing direction. If it's a poisoning, you're going to put the poisoning code first, of course. And if it's an adverse effect, then you're going to have an additional code to show the drug that caused it. Same thing with G92.9. We also have an excludes one note that was revised to traumatic compression of the brain, SO6.A with a dash. And then we have a new code in the circulatory system that we're going to talk about in just a minute. But we also have an instructional note changed for this whole category of ischemic heart disease. Use additional code was revised to code also the presence of hypertension. And as you know, when you're coding CAD, for example, that's not included in that I-11 code for hypertensive heart disease. So they want to make sure that that I-10 or I through I-16 code is captured along with whatever the ischemic heart disease code is. And then we have excludes two notes added for this new code that I'm about to explain to you, I5A. So I'm sorry, hit the wrong button. Here we go. So this is the new code, I5A, for non-ischemic myocardial injury, non-traumatic, acute and chronic and unspecified, or modifiers, non-essential modifiers out beside that. A large code first note here, because just like the type 2 MIs really require that you code the underlying cause first, Same thing with this. The difference, of course, is this is non-ischemic injury versus the type 2 does include ischemia. And you can see a large list of underlying causes that can cause this type of injury. This code is not going to group to the MIDRGs, but instead it's going to go to DRG D314 to 316, which are circulatory system diagnoses, if it is indeed the principal diagnosis. But again, typically it is not going to be the principal diagnosis. It's going to be a secondary diagnosis with the principal diagnosis identifying the underlying cause. They were talking about this in the I-10 coordination and maintenance meeting back in March of 2020. And one of the reasons they developed this code is because we have now high sensitivity troponin tests that can provide explicit information to detect non-ischemic, non-traumatic myocardial injury. And so they want to make sure that they can, capture that. And they also want to make sure they can distinguish between what is a non-ischemic etiology or what is an ischemic etiology. And where there's lack of evidence suggesting myocardial ischemia, a diagnosis of myocardial injury is to be made. That was the final statement made by the Coordination and Maintenance Committee minutes. So just to remind you what the definition of myocardial injury is that came out in 2018. It's talking about when there's evidence of elevated cardiac troponin values with at least one value above the 99th percentile upper reference limit. Myocardial injury is considered acute if there's a rise and or a fall of the cardiac troponin values. Previous to these new codes that just came out, the I5A, we have not been able to code non-ischemic myocardial injury, even though they've been talking about this since 2018. And just again to remind you what the criteria for type 2 is, again, the main distinguishing feature between this and the non-ischemic injury is that it is involving ischemia. And then a heart failure index change that hopefully will clear up some confusion sometimes because of the WITH guideline. If you have heart failure with decompensation, with normal ejection fraction, preserved, reduced ejection fraction, etc., it helps you to, combine those into a more specific code. Sometimes the way the doctor documents the decompensation, you're not able to actually link that to the specific type of heart failure. Hopefully this new index change will make that easier. And then in the respiratory system, we have a couple of code also note changes. In this case for bronchiectasis, use additional code was revised to code also. Moving into the digestive system, we have some new codes for esophageal polyp, K22.81, K22.82, esophagogastric junction polyp, and then K22.89, other specified diseases of the esophagus. So we got a little bit of additional specificity of where the location of the polyp is there. And then we have these new codes. We have gastric intestinal metaplasia without dysplasia. And on the next slide, you'll see the ones with dysplasia. Gastric cancer is the 4th most common cancer in the world. I didn't really realize that. And it's also the 2nd leading cause of cancer deaths. Did not realize that either. And so a finding of gastric intestinal metaplasia is significant for predicting patients who might progress to actual gastric cancer. If you have diffuse gastric IM, it usually involves both the antrum and the body of the stomach. And obviously, the more that's involved of the stomach, the greater risk you are for progressing to gastric cancer. So these new codes are allowing us to capture, how far that's involving the stomach and what sites are involved, whether multiple sites are involved, etc. And then on this slide here are the gastric intestinal metaplasia with dysplasia. Obviously, if it progresses from metaplasia to dysplasia, you're at even greater risk for developing gastric cancer. So they want to be able to distinguish that. And they've got that set of codes split out by low, high grade, or unspecified dysplasia. And I was not able to find any real definitions of what low and high grade mean. Hopefully they'll come out with some additional information about that going forward. In the skin area, we have a new set of codes for L24 related to irritant contact dermatitis. All of these codes, L24A, are related to moisture-associated skin damage. Overexposure of skin to moisture can compromise the epithelial barrier of the skin, making it more susceptible to irritant penetration, and that can lead to dermatitis or inflammation. It's also a huge risk factor for developing a full thickness pressure ulcer, which is, of course, something that people need to monitor. Patients need to be monitored carefully in the hospital setting, especially when they're there for a while, to try to avoid those pressure ulcers. And so you can see here that it's kind of splitting it out by the types of body fluids that might cause the problem. We have an excludes 1 and excludes 2 note here. And then we've got with body fluids unspecified, due to saliva, due to fecal, urinary, or dual incontinence. And then with other specified body fluids, such as endotracheal tube, wounds, fluids, or exudate. And then on this slide, we've got codes specific to stoma or fistula causing that irritant contact dermatitis. Again, they want you to use an additional code to identify the type of artificial opening that the patient had, if applicable. This one is to an unspecified stoma or fistula. This is a digestive, respiratory, fecal, or urinary. And then we have a new guideline related to unstageable pressure ulcers. And they're basically saying that if during the encounter, the unstageable pressure ulcer is revealed after debriding, and as you remember, unstageable pressure ulcers are covered by eschar or tissue that doesn't allow them to see how deep the ulcer is. And if they take the top of that off with debridement and they can see how deep it is, and they give you the specific stage later in the stay, they're telling us to assign only the code for the stage revealed after the debridement was done. In the musculoskeletal system, we have this thrombotic microangiography, unspecified. They've added some explanatory phrases, and then they've given us a split, some additional codes here. M31.11, hematopoietic stem cell transplantation associated thrombotic microangiopathy. That's a big mouthful, otherwise known as HSCT-TMA. Transplant associated thrombotic microangiopathy, or TMTMA. Code first, note, they want to code first the complication of a bone marrow transplant or a stem cell transplant if that occurred, and then they have a use additional code to specify different organ dysfunctions that might occur in conjunction with this. And then we have the 31.19 other thrombotic microangiopathy. Also moving on further into the musculoskeletal system, we have a code also note here under this M34.81, systemic sclerosis with lung involvement. So that if they have interstitial pulmonary disease, you have a code for that, or secondary pulmonary arterial hypertension. All of these codes, and as I mentioned this earlier, we got a bunch of new codes out. I don't know if that was last year or the year before. For Sika syndrome, they are revising those or retitling all those to Sjogren's syndrome instead. So you'll see that, mentioned in different places throughout the coding changes for this year. And we have a use additional code note here, as well as a new excludes 1 note. And then we have this new code specificity here for Sjogren's related to inflammatory arthritis, so that you can capture which nervous system involvement, or if it's GI, glomerular disease, vasculitis, or dental involvement. So you can give some specificity to where that arthritis involvement is occurring. We also have this M3581 multisystem inflammatory syndrome, which is post-COVID-19 condition. And when you have the code for that here in parentheses, it was added to the use additional code note for that code. This syndrome you've probably heard about in the news over the last year. It's associated with past or present COVID-19 infections, has been predominantly found in children, less frequently in adult. It's also been called the Pediatric Inflammatory Multisystem Syndrome. The current U.S. definition for MIS in children includes fever, lab markers of inflammation, severe illness requiring hospitalization, with at least 2 organ systems involved, and lab evidence of COVID-19 infection, and a history of known exposure to COVID-19 within 4 weeks prior to symptom onset. They definitely want to capture this as much as they can because of the impact on children, because many of them have really been sick or even died from this. And then we have some code first additions to these codes here. A guideline related to that multisystem inflammatory system. It's basically telling you that you would assign this M35.81 code along with U09.9 indicating a post-COVID condition unspecified. And then we have this new set of spondylitis codes under ankylosing spondylitis. The 45A codes are for non-radiographic axial spondyloarthritis. And the reason it's called that is because unlike ankylosing spondylitis, where you have X-ray changes in the sacroiliac joint that show up, you do not have that with the non-radiographic, which is why they've called it that. This is a little bit less severe than the ankylosing spondylitis. They want to, capture it. They want to know which joints are involved, so that they can kind of follow that, because sometimes this is considered kind of an early stage of the more serious ankylosing spondylitis that we've been able to code before, and they want to make sure they can distinguish that and kind of know patients that are kind of progressing toward that. And then we have some new low back pain codes that have been split out. M54.50, M54.51, which is vertebrogenic low back pain, and then other low back pain. Nothing I really want to say on this particular thing. There's just, changes to the instructional notes. OB, they basically have added some wording here in the final character for trimester when the classification does not give you an obstetric code with an in-childbirth classification option. It is appropriate to assign a code describing the current trimester. And then they've just added the word patient periodically through these little guidelines here. Same thing here. And then the 094, or 094, I should say, the sequela, has just added a couple of sentences there, or a couple of words rather. In the perinatal period, we've just got basically changes in notes underneath those codes. But I did want to talk about this new code here for newborns affected by other maternal conditions, P00.82, when they're affected by maternal group B strep, colonization, and then when they're affected by others. Typically, the mother is not going to have any adverse effects from having group B strep. However, it can really affect the baby and cause some serious problems. So they want to be able to capture that more carefully than we've been able to in the past. And then in this chapter 16, again, we've got a used additional code note that was deleted under P09. And these are basically types of screening, neonatal screenings, and they've added more specificity for the types of screening so you can capture, in the data, whether it was for endocrine, hematologic, cystic fibrosis, etc. Signs and symptoms. I told you earlier in the presentation that we have more specific codes for cough. Not totally sure why the American Thoracic Society and the American College of Chest Physicians felt the need for this, but in looking at this, you can see that it's characterized by how long the cough lasts primarily. Acute is considered a cough that has less than 3 weeks duration, often associated with a respiratory condition. Subacute is differentiated between that and acute because it has a longer duration of 3 to 8 weeks. Chronic is persistent, refractory, can't explain it, just goes on. And then we have cough syncope, which I've never seen documented before. and note the code first. Note under that you would code the syncope code first, and then the cough syncope is a secondary diagnosis. Basically, the duration of the cough kind of helps them decide how they're going to treat these coughs and how they're going to follow these patients. And apparently chronic coughs can have a real impact on patients' overall health and well-being. Often patients end up developing clinical depression because of a cough that they just can't get rid of. We have a new code here for non-suicidal self-harm, R45.88. That is defined as someone who's causing themselves harm, such as cutting, hitting, or even breaking their bones, but they don't have any intent to commit suicide. And obviously, they're going to be, treating them to try to figure out why they're causing self-harm if they're not trying to kill themselves, and how they can help, manage that for them and get them some help for that. And then you see this new specificity added for feeding difficulties, R63.30, unspecified feeding difficulties, and then pediatric feeding disorder acute, with a code also note that goes along with that. We have a code also note, again, continuing on with the pediatric feeding disorder for chronic, giving you instructions about some other things to code if they have that chronic condition. And then R63.39 for other feeding difficulties. This code here, this R79.83, is a new code. Basically, Homocyst Anemia is an abnormal blood amino acid level. And prior to this change, that was grouped in the same code with homocystinuria, which is very different. And they want to make sure they can separate that out so that they can keep that separate, the blood amino acid level separate from the homocystinuria, and start trying to follow that and figure out what's going on, because they found that having this in the blood can be an indicator of higher than normal cardiovascular risk. So they want to make sure that they can follow that more closely than they've been able to. Then we have a guideline change related to, or additions related to coma. Code R40.20 is unspecified coma. And underneath this underlining part, it says, do not report codes for unspecified coma, individual or total. Glasgow Coma Scale scores for a patient with a medically induced coma or a sedated patient. That's underlined because that was already in the previous guideline, and they just added this unspecified coma documentation here. They've made some changes to the coma scale scores that were listed in the guideline. And then they're basically, I think there was a coding clinic talking about this, but they've added it to the guidelines that if you have multiple coma scores that are captured within the first 24 hours, you only assign the first one at admission, because we don't have a way in the coding classification to classify coma scores that go downhill within the first 24 hours. And again, remember, we used to be able to use these GCS scores with things other than a traumatic brain injury. But I think last year, maybe even the year before, they changed that. So the use of these codes is restricted to patients with traumatic brain injury only. And I find errors when I'm auditing these codes that people are still coding it with strokes and some other things. So be reminded that you only use it with traumatic brain injury codes. Then we have an aspiration index change. Sometimes when the patient aspirates and you go to look that up and code it, it has asphyxia food. That's caused a lot of confusion because the doctor rarely, I don't know if I've ever seen a doctor write that word on the chart or document that or anything. And so you don't know what to do with it. So they've changed this so that when you are trying to code aspiration of food or foreign body, it says see foreign body by sight, which I hope will help. And then in the injury area, we have a use additional code note added to SO6.2 for diffuse traumatic brain injury. Same thing added for this other code categories here. And then we have some additional codes. Prior to this, we were not able to identify traumatic compression that had brain herniation along with that. And so they've added these codes one for without herniation and one for with herniation, along with brain compression or cerebral compression. So that's going to be helpful to have that clarified. Those are MCCs, as you can see. And then just this little excludes note was revised to remind us that a periprosthetic fracture is occurring around the prosthetic implant itself. And then a little guideline addition here for burns and corrosions related to extended body surface. The last sentence here, codes from categories T31 and T32 should not be used for sequela of burns or corrosions. In the poisoning arena, we've got new categories. The first set is T40.711 through 16 related to underdosing, adverse effect or poisoning of cannabis. And then 40.72 through 21 through 26, 721 through 726 rather, for synthetic cannabinoids. And then they've deleted this whole chapter, or this whole section of codes, T40.7X, which were replaced by the slides I showed you on the previous slide. Or not the slides, but the codes I showed you on the previous slide, excuse me. Complications, we have a new code. We talked about the immune effector cellular therapy, or the CAR T cell therapy previously in this presentation. They want to make sure that we can capture the number of patients who are actually having those complications to the CAR T cell therapy. So they've added this code. They've got an excludes to note here so that you can code also whether they had a complication to a bone marrow transplant or stem cell transplant. And I use additional code to identify whether it's cytokine release, like we talked about earlier, or the immune effector cell associated neurotoxicity syndrome in the G92.0 category that we talked about previously. They also revised the excludes one note here. Instead of wording it as anesthetic shock, they've changed it to shock due to anesthesia. Not sure the reason for that, but nevertheless. This is the only change to the external cause codes for this year. This Y35.899, legal intervention involving other specified means, unspecified person injured. And then in the Z code arena, we have some changes. These first ones are related to screening codes and immunization codes. In this immunization code right here, they're wanting you to code also encounter for immunization safety counseling, and we're going to talk about that code in a little bit later slide. And then in the Z28, immunization not carried out and under immunization status, they want you to code also whether they had safety counseling. I'm sure that these are being added in here related to the number of people that are not getting COVID vaccines, and they want to make sure that they can capture whether people are getting counseled about what they're doing, etc. And those are non-CC codes. And then now we start into some changes related to the social determinants of health codes. We have a new code here, Z55.5, capturing that patient has less than a high school diploma. We have new codes for a new code for problems related to physical environment. This is Z58.6, inadequate drinking water supply, with an additional code that you can add along with that if appropriate. And then we have new codes for homelessness, unspecified, sheltered homelessness, and they've got that sort of defined here on the slide for you, and unsheltered homelessness, and they've defined that here on the slide as well. And then lack of adequate food and safe drinking water was revised to state it as lack of adequate food. They revised the excludes 1 to 2. They have a new code here, Z59.41, food insecurity, and Z59.48, other specified lack of adequate food. And then we have some housing instability here in this Z59.81. Again, housed is defined for you. And then they have additional specificity underneath here. 0.811 would be with risk of homelessness. 0.812 would be homeless in the past 12 months. 0.819 would be unspecified, whether they had any homelessness. And then Z5989, other problems related to housing and economic circumstances. And I'm sure you're probably aware of the fact that they are definitely interested in us doing a better and better job of capturing this information, because it's really becoming an important aspect in monitoring patients' overall health and well-being and their care. We have this Z7185 that I mentioned previously about Encounter for Immunization Safety Counseling. And basically, that is to be assigned when a patient comes in specifically for vaccination counseling, including alternative vaccines, alternative vaccine schedules, or vaccine safety. So as I said, I'm sure that's primarily related to the COVID-19 issue. And then we also have an excludes one note here under Z79.4 that does allow us to code both of those codes together since they revised that guideline October 1. We have this personal history of COVID-19 code with an excludes one, adding that U09.9 code, which is a new code. And then we have a note here related to the personal history of non-suicidal self-harm. This allergy to mammalian meats here, as you can see in the parentheses, these are red meats. This is primarily caused by a tick bite. The Lone Star or the deer tick can trigger an immune system reaction that suddenly causes patients to start having an allergic reaction to red meat. We have the history of the cellular therapy or the CAR T cellular therapy that we talked about here. And then we had this excludes one note that was deleted because it made absolutely no sense to have that underneath that dependence on enabling machines and devices code. Then we have some guideline additions, history of the reason for the encounter should be sequenced first, and the personal or family history code should be signed as an additional diagnosis. And then for the new counseling codes, it's to be used for counseling regarding the safety of vaccines, like I just told you previously. And then we have some additions to the social determinants of health guideline. What is in bold is what's been added. What's underlined is what we already had from last year. They're basically saying, that we can now use clinicians, documentation, like we talked about at the very beginning of the presentation, from social workers, community health workers, case managers, nurses, etc., as long as it's included in the official medical record. And then they talk about patient self-reported documentation. This is already in the guideline for last year. And here's a list of the categories of social determinants of health on this slide right here. Then we have some changes to Chapter 22, the COVID guidelines and the COVID codes. We have this new U09.9 that we've already talked about a few times for post-COVID-19 conditions unspecified. And this basically is going to replace the B94.8 sequela of other specified infectious and parasitic diseases that we were told to use prior to this. As you are probably aware, you've heard about long haulers with COVID-19 that end up having long-term effects that just go on and on and on. And that can be a lot of different things. They can have chronic respiratory failure, loss of smell or taste, this multi-system inflammatory system that we talked about, pulmonary embolism, etc. So they basically want you to assign this code, but they want you to code first what are those long-term effects so that they can start tracking the number of people that have those and what they are, etc., to try to understand this virus better and come up with better treatments for it. And then we have basically this guideline that adds that new code that I just talked about. And these new guideline additions here, post-COVID-19 conditions. For the sequela, it tells you to sign a code for the specific symptoms, like I just said, and then the U09.9 is a secondary. And then it talks about it should not be assigned for manifestations of an active or current COVID-19 infection. And it goes on to say that if they had a previous infection and they develop a new active infection, You can use that code in those cases to talk about sequela from the previous one, but then you have to code the current condition with the appropriate U07 code, etc. Well, going back to that slide for a minute, this is going to get tricky in terms of documentation from the physician, because I don't know about you, but I've seen a lot of cases where it's really not clear whether they think the patient still has an active COVID infection, or, whether it's still, it's a history that's been cured and they're just treating the sequela. So we're definitely going to have to be working on the physician documentation to be able to use this guideline effectively and appropriately. And then I just wanted to briefly touch on, before we close out here, the latest FAQs for COVID came out recently. So make sure you have the latest set of those questions so that you can look over those. And they have added a couple of, coding scenarios. I just included here on the slide 2 of them using that new code of U09.9. And basically, if the documentation says that the patient had pneumothorax or pulmonary embolism due to a previous COVID-19 infection, you're going to code it to that particular condition, and then you're going to add the U09.9 as a secondary to explain that it is a sequela of the previously cured or healed COVID-19 infection. And again, a reminder that if you can't tell for sure whether it's a current infection or not, that you are going to have to query the physician. And I have a list of references here that I use to pull all this information together. So with that, Sharon, I'm done, and I'm going to turn it back over to you to talk about the CE issue.
Thank you, Joy. You laid that out so clearly. I thought it was really well organized, so thank you very much. So just to let everybody know, if you want to receive your AHIMA CEU certificate, the directions are right here. You can just visit this link. You'll have to type it into your browser and note the spelling of TrueCode. There's no E after the U in TrueCode, but you can just put that in your browser and submit a brief evaluation, and you should be able to download your CEU certificate. And again, any problems or questions, feel free to reach out to me. I am happy to help. All right, thank you, everyone. And thanks again, Joy. We hope to see you all on another webinar soon. Take care.